TIA and stroke, nice guidelines. For TIA, first we make the initial diagnosis. We use a rapid toolkit like FAST, face, arm, screen test, outside the hospital to assess stroke risk in patients with sudden onset neurological symptoms. We can use the ROSIER, or the Recognition of Stroke in the Emergency Room toolkit, to diagnose stroke in the emergency room. We have to rule out hypoglycemia. Unless contraindicated, we give aspirin 300 milligrams to all patients. We refer to a specialist within 24 hours. We do not use assessment tools like ABCD2 scoring to inform urgency of referral. We offer secondary prevention in suspected TIA. We do not use a CT scan for initial assessment of a TIA or stroke without deficit unless alternate diagnosis is suspected. We have to use an MRI with diffusion-weighted images within the same day as the suspected TIA. Carotid imaging is offered to everyone who may benefit from a carotid endarterectomy after specialist assessment. For symptomatic carotid stenosis of 50 to 99%, that is by the NASCET criteria, carotid endarterectomy is advised. For stroke with deficit, we do a CT head plane if there are indications for thrombolysis or thrombectomy, if the patient is on anticoagulation, there is any known bleeding tendency, there is a depressed level of consciousness with a GCS of less than 13, there's unexplained progressive or fluctuating symptoms, papilledema, neck stiffness or fever, severe headache at the onset of the stroke. All stroke patients should be referred immediately to a stroke unit. Thrombolysis with alteplase is indicated in ischemic stroke if the symptoms are within 4.5 hours of onset and intracranial hemorrhage is ruled out. We offer thrombectomy in 6 hours if confirmed occlusion of the proximal anterior circulation, which could be demonstrated either by a CTA or an MRA. We offer thrombectomy in 6 to 24 hours if acute ischemic stroke with confirmed occlusion of proximal anterior circulation and there is a potential to salvage brain tissue, that is, there is limited infarct volume. We do not use anticoagulation routinely for an acute stroke, but we do use anticoagulation immediately for venous stroke, as in a sinus thrombosis, first with heparin and then warfarin. Reversal of a hemorrhagic stroke secondary to anticoagulation is by IV vitamin K plus prothrombin complex concentrates. We offer rapid BP lowering in acute intracranial bleed if presenting within 6 hours, and those who have systolic BP of 150 to 220 millimeters of mercury, and aim for a target of 130 to 140 millimeters of mercury within 1 hour of starting treatment, and maintain this for 7 days unless contraindicated. We offer the same in intracranial bleed if presenting after 6 hours, and if the BP is more than 220 millimeters systolic, unless contraindicated. We do not offer rapid BP lowering in intracranial bleed if there is an underlying structural disease like a tumor or an AV malformation or an aneurysm, or if the GCS is less than 6, or if the patient is going for neurosurgery to evacuate the hematoma, or if there's a massive hematoma with a poor prognosis. In acute ischemic stroke, we consider BP lowering to less than 180 by 110 millimeters mercury if considered for thrombolysis. In acute ischemic stroke, we consider BP lowering only if there is hypertensive encephalopathy, hypertensive nephropathy, hypertensive cardiac failure or MI, aortic dissection, or preeclampsia. Immediate initiation of statins is not indicated in acute stroke, but should not be stopped if the patient is already on it. Oxygen is indicated only if the saturation is less than 95%.